All right, so today we're going to talk about right to left shunts. And this is the diagnostic set where we have cyanosis with decreased pulmonary blood flow. And as far as the approach here, what we do from the plain film, as far as the plain film goes, is we look at the heart size and specifically the appearance of the right atrium. So if there is no cardiomegaly, if the right atrium is not particularly enlarged, then here we're dealing with non-restrictive intracardiac shunts with pulmonic stenosis. So here the first thing on the differential diagnosis would be what? Yeah, Tetralogy of Fallot. On the other hand, and then Tetralogy of Fallot-like lesions, which we will discuss. On the other hand, when we do have cardiomegaly, especially when the right atrium is enlarged, here what's going on is usually a right to left shunt through the atrial septum, through an atrial defect, and there's some obstruction to blood flow in the right heart. The ventricular septum here in these cases is usually intact. And here the big lesion, the lesion that we start with, is what lesion? Right. So here Ebstein's would be the lesion that we start with. But in terms of the entire differential diagnosis, right to left shunts with no cardiomegaly, and again, non-restrictive intracardiac shunt, usually a VSD with pulmonic stenosis, Tetralogy of Fallot and Tetralogy of Fallot-like lesions. These are admixture lesions, usually with pulmonic stenosis, especially if they have a ventricular septal defect. And then we have pulmonary atresia with intact ventricular septum type 1, which we'll also discuss a little bit. On the other hand, if you have right to left shunts with cardiomegaly, here we usually have a right to left shunt via an atrial defect, and there's some obstruction of blood flow in the right heart. The ventricular septum is usually intact, and then the big lesion in this category is Ebstein's. And then there's pulmonary atresia with intact ventricular septum type 2, some variants of tricuspid atresia, and then we'll talk a little bit about the other lesions in this category also. So we'll start with this case. Who volunteers to take this case? Somebody? Who's that? Jason. Okay, very good. So Jason, what we'd like to do is we'd like to start with this guy here. What is this guy? IVC, because the IVC takes us to, and then this guy over here would be, right. So with congenital heart disease, it helps to read the studies from bottom up. So the first thing you want to identify, IVC, right atrium, left atrium. Now we want to look at the ventricles. So we follow the IVC, it takes us to the right atrium. What do we think this is? And then this over here would be, and then when you look at the right and left ventricles, did you notice anything about the ventricular septum? So let's go through that again. So there's the right ventricle coming up. Here's the left ventricle, right? And then anything about the ventricular septum. So let's look at that again. So here we have the right ventricle. Here's the left ventricle. Here's the septum. What is that here? Right, so there's a ventricular septal defect. So now we've identified the atria, we've identified the ventricles. Now you want to look at the outflow from the ventricles, okay? So now we'll look at the right ventricular outflow. And here the right ventricle is connected to what? Well, what about the pulmonary artery? Where does the pulmonary artery come off? Okay, so the pulmonary artery we see is also coming off the right ventricle. Now, is there any communication of the aorta with the left ventricle in this case? Okay, so, and what do you think of the outflow tract of the right ventricle as we go through this? So here's the outflow tree. Well, look at the, yeah, go ahead. Well, so here, when we look at the right ventricular outflow tract, when it takes us to the pulmonary artery, right? What do you think of the infundibulum? Is that normal in size or is it narrow? It's narrow. So what are we dealing with here? Right. And you have infundibular stenosis. Now, the aorta, you said, was receiving flow from both ventricles, right? So what do we call that? Well, it's not truncus because they're two separate vessels. The aorta and the pulmonary artery have two separate valves, right? But the aorta is getting flow from both ventricles because it's on top of what? Yes, it's an overriding aorta because it's sitting on top of a ventricular septal defect, right? So this is a case of tetralogy of Fallot, okay? So as we go down, here's the aorta, there's the pulmonary artery. So pulmonary artery, aorta. Notice also that the aorta is bigger than the pulmonary artery, at least the root of the aorta, and that's always a good sign for a right to left shunt because the pulmonary artery and the aorta are usually normal in size. But as we travel down in this case, and we get down to the root of the aorta and the pulmonary artery, you'll notice that the aorta is bigger than the pulmonary artery. And again, when we're dealing with congenital heart disease, that usually indicates a right to left shunt. Okay. So, what are anybody else? What are the four elements of tetralogy of Fallot? We just kind of went through them. What are they? List them, please. Infundibular pulmonic stenosis. So stenosis of the outflow tract of the right ventricle. What else? Overriding aorta. Yes. It overrides what? Right. So that's three things you've covered so far. So the fourth thing is right ventricular hypertrophy. Right. Those are the four elements of tetralogy of Fallot. What is pentalogy of Fallot? If we add one more thing on that, we get pentalogy of Fallot. What's that one more thing? ASD. Right. Now, what is pink tetralogy? Yes. Right. So the infundibular stenosis is not as bad. So there you have a ventricular septal defect, and you might actually preferentially have left to right shunting because of the ventricular septal defect. In any event, they're not cyanotic because they don't have enough. They don't have enough right to left shunting to cause cyanosis. That is pink tetralogy. Okay. So the four elements of tetralogy of Fallot. We've talked about pentalogy already. Okay. Now all of these elements of tetralogy of Fallot is caused by just one abnormality, and that abnormality is maldevelopment of the conal septum. So if you take this infundibulum and embryologically, if it's displaced a little bit too far anteriorly towards the right ventricle, that's what results in narrowing of the outflow tract of the right ventricle. So that gives you infundibular stenosis. All of the other problems follow from that. So, because of the abnormal position here, it cannot fuse with the ventricular septum completely, so that leads to a ventricular septal defect. And then, because of that shifting towards the right ventricle, the aorta then moves over and overrides the ventricular septal defect. The infundibular stenosis results in right ventricular hypertrophy because of the obstruction to the outflow tract. So all of these elements of tetralogy of Fallot are just caused by one embryologic abnormality, that abnormal anterior displacement of the septum here in the infundibular region. There's usually a reciprocal relationship between the size of the aorta and the pulmonary artery. As the infundibular stenosis gets worse and worse, as the pulmonary artery gets smaller and smaller because of more obstruction and decreased flow, the aorta tends to get larger because there you have more right to left shunting into the aorta. Okay. Now there is a spectrum of severity. We've talked about pink tetralogy already, where the infant. Somebody have a question? Okay. So we've talked about pink tetralogy already, where the infundibular stenosis is not severe enough, and then there you might have predominantly left to right shunting across the ventricular septum. And then at the other end of the spectrum, you have end-stage tetralogy, also called pseudotruncus arteriosus, where you have pulmonary atresia. So there is no outflow from the right ventricle here. And so there's going to be a lot of right to left shunting, and these patients will have severe cyanosis. And then the lungs may be supplied by these collateral vessels that come off of the descending thoracic aorta when you have that pulmonary atresia here at the kind of the most severe form of tetralogy of Fallot. Okay, so we can have pink tetralogy, we can have balanced tetralogy where the left to right shunting is kind of equalized by the right to left, but with classic tetralogy, there the predominant shunting is right to left shunting with classic tetralogy of Fallot. So we've talked about pink tetralogy. Here's kind of an example. As all the morphologic elements of tetralogy, there's some narrowing of the outflow tract. There's a ventricular septal defect overriding aorta. Might have some right ventricular hypertrophy there. But the infundibular stenosis is not enough to cause predominantly right to left shunting. So these patients, the pulmonary blood flow may look normal or may actually be increased because of the ventricular septal defect and left to right shunting. Okay? And then with balanced tetralogy, the radiograph does not show any abnormalities in terms of pulmonary blood flow. And then with classic tetralogy, we'll have the manifestations on the radiograph. So patients are usually acyanotic until 3 to 6 months of age, so they're usually not cyanotic at birth. After age 4, tetralogy of Fallot is the most common cyanotic congenital heart disease. So cyanotic spells can occur because of spasms of the infundibulum, which cause severe obstruction during the spasm, and patients may use squatting to relieve dyspnea by increasing systemic vascular resistance that decreases the amount of right to left shunting. Other complications, endocarditis, and also brain abscesses, whenever you have right to left shunting, you can have bacteria that enter the systemic, can get into the systemic circulation. Bacteria are always entering the venous circulation. But if you have then right to left shunting, then without being filtered by the capillaries in the lungs, those bacteria have direct access then to the systemic arterial circulation, and brain abscesses can be one manifestation of that. So some examples of narrowing of the outflow tract, infundibular stenosis with tetralogy of Fallot. Now it can also be associated with valvular and supravalvular pulmonic stenosis. Branch pulmonic stenosis can also occur, especially at the origin of the left pulmonary artery in these cases. The overriding aorta means that the aorta overrides a ventricular septal defect. So this allows the aorta to receive blood from both ventricles. Okay, so it receives naturally, it should receive blood from the left ventricle, but it can also receive blood from the right ventricle from the overriding position of the aorta. And then the hypertrophy and the ventricular septal defect, so all of those follow from the abnormal position and the infundibular stenosis. So here you have an example of infundibular stenosis there in the outflow tract of the right ventricle. Nice example of right ventricular hypertrophy. Here's the ventricular septal defect, and here is our overriding aorta there. Okay? So with pink tetralogy, as we've said, you have all of the elements of tetralogy of Fallot, but the infundibular stenosis is not enough to cause predominantly right to left shunting. So this kind of came up in the case that we started with. So what is the difference between, notice that the aorta does receive blood from both ventricles. Of course, the pulmonary artery also receives blood from the right ventricle. But what is the difference then between tetralogy of Fallot and double outlet right ventricle? So what is that cutoff? Yeah, exactly. So it's considered double outlet right ventricle if more than 50% of both great vessels, more than 50% of the pulmonary artery and the aorta are connected to or receive are connected to the right ventricle. So you can see how closely this is related to double outlet right ventricle, how closely these anomalies can be related. I mean, if the aorta shifts more towards the right ventricle, then you have a case of double, then, we call it double outlet right ventricle. And the physiology, of course, does resemble, if there's infundibular stenosis, tetralogy of Fallot. So right aortic arch, this is also strongly associated with tetralogy, about 20 to 25%, and it's right arch with mirror image branching. So the branching is just the opposite as with the normal arch. So mirror image branching is associated with congenital heart disease, and if we have a right arch with congenital heart disease, then we usually have mirror image branching. So tetralogy of Fallot and truncus are two congenital heart diseases that are associated with mirror image branching in right aortic arch. The severity of the pulmonic stenosis tends to also increase with the frequency of the right arch. So those patients with right arch tend to have more severe pulmonic stenosis. Now, the radiographic manifestations of tetralogy of Fallot. So what are the radiographic manifestations? Who wants to tell us? Yes, we always start with the pulmonary vascularity. So there will be decreased pulmonary vascularity, which tells us the patient will have cyanosis, right? What else? Yeah, so upturning of the apex, which is caused by the enlargement of the right ventricle, and this has been called the boot-shaped heart from the upturning of the apex. And in this case, has one more bonus feature. What's that bonus feature here? Yes, the right aortic arch. So there is a right aortic arch in this case too. So that can also be associated with tetralogy of Fallot. So those are the radiographic manifestations of tetralogy of Fallot: decreased pulmonary vascularity, upturned cardiac apex, the boot-shaped heart, prominent ascending aorta, and there might be a right. This one has a left arch, but you might have a right aortic arch in up to 50% of cases. Now, even though that's the classic appearance, it turns out in real life the boot-shaped heart is not really as frequently seen as we would want it to be seen. So most cases of tetralogy of Fallot actually don't demonstrate a boot-shaped heart. So don't be disappointed in clinical practice if you don't come across the boot-shaped heart. Okay, but the stenosis here, the pulmonary stenosis, right aortic arch, all of those things can be associated with tetralogy of Fallot. So here's a case in an adult who has the right aortic arch and the upturned apex there. This one has a left arch with an upturned apex. Okay, so here's another case. Patient who has decreased pulmonary vascularity, will be cyanotic, upturned apex, right aortic arch. So by all rights, this should be a case of yeah, this should be another case of tetralogy. But when we look at the imaging, of course, we have the right aortic arch, right? We have the ventricular septal defect. We have the right ventricular hypertrophy. Is there anything that looks peculiar here? There, there is a VSD, right? Well, I'm not showing you the rest of the right ventricle. There is a VSD, but what's missing here? No, this is going to the left atrium. But what's missing here? What should you see here that you don't see? Yeah, the pulmonary artery is missing. So this is a case of pulmonary atresia. So this is at that very severe end of the spectrum of tetralogy of Fallot, where the outflow is completely obstructed and you don't see the pulmonary artery. So how does then the how does the lungs receive blood flow? Well, you might have these dilated vessels here that are coming off of the aorta, supplying the lung. So what are these called? There's a term for these collateral vessels when there's severe pulmonary outflow obstruction that can supply the lungs. What are these vessels called? Yeah, so these are called major aortopulmonary collateral arteries. And so these can come off the descending thoracic aorta to supply the lungs if you have severe outflow obstruction or pulmonary atresia where the lungs are not being supplied by the pulmonary artery. So those are major aortopulmonary collateral arteries. And so remember we talked about pseudotruncus arteriosus where you have vessels going to the pulmonary arteries coming off the descending thoracic aorta. So this is really not truncus arteriosus. This is at the severe end of tetralogy of Fallot when we have pulmonary atresia. Okay? All right, so with severe pulmonary stenosis or atresia, there may be these funny-looking vessels that we see. We don't see the pulmonary arteries here, so that's what these circles are showing us. But you may have these funny-looking vessels that are going out into the lung parenchyma, and those are those collateral vessels, major aortopulmonary collateral vessels. So they don't look like normal pulmonary arteries, even on the plain film, when we look at those. Okay, they're kind of small and stringy looking. Now, there's a coronary anomaly that is also associated with tetralogy of Fallot, and it's illustrated here. So, what is that anomaly? And what's the significance? Well, the anomaly has to do with the left anterior descending coronary artery. So what's the anomaly here having to do with the left anterior descending coronary artery? And what is it doing as far as the course? Yeah, so the anomalous vessel then goes across. So there's a vessel with the anomalous origin goes across the outflow tract of the right ventricle. Now, why is that important? Why is that significant? It's important, yeah, for surgical planning, right? So it's important because during surgery, to relieve the outflow, they have to cut into the right ventricle and they have to relieve that infundibular stenosis from the outflow tract. And so if there's a coronary vessel that is cutting right across the outflow tract of the right ventricle, that, of course, is something that the surgeons do need to know about. Okay? So aberrant LAD, the LAD arising from the right coronary artery, so that can cross right across the outflow tract of the right ventricle. So that is also associated with tetralogy of Fallot. Now, this patient has tetralogy of Fallot. When you look at the plain film, why is that hard to believe? What's peculiar about the plain film that makes it hard to believe that this patient has tetralogy? Well, the central pulmonary arteries are markedly enlarged, right? So you notice that enlargement of the central pulmonary arteries. Now, we talked about pink tetralogy, where you might have predominantly left to right shunting. That, of course, could do this. But what other anomaly associated with tetralogy of Fallot can result in dilatation of the central pulmonary arteries? Yeah, and what is that? Right. So absence of the pulmonic valve results in severe pulmonary regurgitation. And that severe pulmonary regurgitation then results in dilatation of the central pulmonary arteries. So congenital absence of the pulmonic valve occurs in a small percentage of cases of tetralogy of Fallot and results in severe pulmonary regurg, and then you have the confusing appearance where the central pulmonary arteries actually appear dilated in somebody with tetralogy of Fallot. Yeah, yeah. Yes, absolutely. So what? So after what procedure? Well, the procedure that that was done for tetralogy and can still be done as kind of a temporizing measure until they get to more definitive surgery is what? The original procedure that was done for tetralogy of Fallot was, what was that called? Blalock-Taussig shunt. So a Blalock-Taussig shunt is a shunt from the subclavian artery to the pulmonary artery to increase the blood flow within the pulmonary circulation. And now that might be done in some cases until they can do more definitive surgery as a palliative measure. So in those cases, if in that shunt there's too much blood going into the pulmonary circulation, if there's too much blood going through that shunt, then you can have dilatation of the central pulmonary arteries, or you converted a condition with decreased pulmonary blood flow to a condition of increased pulmonary blood flow. So you're right. That can be a complication of a surgical procedure also. Okay? So absence of the pulmonic valve can give you central dilatation, as we said, of the pulmonary arteries. Okay, so who's going to take this case? All right, Dante, give it a try. Are you ready? Dante, are you out there? All right, anybody else? Doug? All right, Lamb. Okay, so we start with this guy. This guy is. All right, so we'll start. Well, again, we start from the bottom, right? So, and that will take, the IVC will take you to what? Right, so that takes you to right atrium. So this guy is, that will be left atrium, right? So now we want to look for the ventricles, right? So over here, that guy you think RV, okay, so let's go through that again, right? And then on the other side, this will be LV, right? So the right atrium is connected to the right ventricle. The left atrium is connected to the left ventricle. So we have atrioventricular concordance. And when you look at the ventricles, do you notice anything else in there? Right, so there's a large VSD. So now we want to look at the outflow of the ventricles. What are the ventricles connected to? Okay. Okay, so this guy here, right? So that guy looks like a right aortic arch. So the RV is connected to the aorta. All right, so now you have to look for the pulmonary artery. Where does the pulmonary artery come from? Well, did you find did you find the pulmonary artery? Yeah. So where's the pulmonary artery? Let me know if you see where it is. Well, first let's find the pulmonary artery. So this guy here is the pulmonary artery. See it? Okay, well, let's take a look. Follow it. Did you see the pulmonic valve? Were you able to find the pulmonic valve? Okay, so here's the pulmonary artery, right here. Here's the pulmonic valve, right? So is the pulmonary artery, do you think, connected to the left ventricle or the right ventricle? It's the right. Now, why did they think this patient had tetralogy of Fallot? Exactly, right. Notice also the pulmonary artery is small compared to the aorta. In congenital heart disease, when the aorta looks larger than the pulmonary artery, we think about a right to left shunt. And here you can see the infundibular stenosis. There's narrowing of the outflow tract. So here's the right ventricle, there's the aorta, here's the pulmonary artery. You can see there's narrowing of the outflow tract here. There's infundibular stenosis. Okay, so what does this person have? What are we going to call this? Right, so it's double-outlet right ventricle with What other problem did you mention? Pulmonic stenosis, right? And ventricular septal defect. So that's why the physiology resembles Tetralogy of Fallot, right? So this will give you then predominantly right to left shunting because of the infundibulary stenosis and because of the ventricular septal defect. Okay. So as we go down from the top, right aortic arch, there's the aorta here, ascending aorta, comes down, comes off the right ventricle. There's that small pulmonary artery, and then that also comes off the right ventricle. Okay, so it's a case of double outlet right ventricle with stenosis of the outflow from the right ventricle. Okay? Now, these admixture lesions, if we superimpose pulmonic stenosis on the admixture lesions that we talked about in the last lecture, especially if there's a VSD, the physiology will resemble Tetralogy of Fallot. So clinically, they will resemble Tetralogy of Fallot, and on the radiograph, they might have findings also that resemble Tetralogy of Fallot. So any admixture lesion, if there's a VSD and we superimpose pulmonic stenosis, will resemble Tetralogy of Fallot. So all of these are examples: single ventricle, transposition, double outlet right ventricle, with superimposed pulmonic stenosis, the radiographic manifestations of decreased pulmonary blood flow, upturned apex, sometimes even, it will look like Tetralogy of Fallot. And clinically, it will also resemble Tetralogy of Fallot. Okay? So, transposition with pulmonic stenosis and VSD, 30% of transpositions have pulmonic stenosis and VSD. So, cyanosis is milder, survival is better when there's pulmonic stenosis because of decreased risk of CHF. So, it kind of prevents the overflow of blood going into the pulmonary circulation, right? Especially if the left ventricular blood is directed through the VSD to the aorta. Right? Single ventricle with pulmonic stenosis, very similar. If there is no transposition in case of single ventricle, that is usually associated with pulmonic stenosis. And there also, the physiology can resemble Tetralogy of Fallot. With tricuspid atresia, the size of the atrioseptal defect can also affect the radiographic appearance. So the most common form of tricuspid atresia, normally related great arteries, pulmonic stenosis, small restrictive VSD, these patients will have cyanosis at birth. But the important thing is, when there's tricuspid atresia, the only outflow from the right atrium is through the ASD. So if there's a large ASD, then the right atrium will not dilate. But on the other hand, if there's a small restrictive ASD, then the right atrium will dilate. So this might resemble tetralogy on the plain film, and this might resemble more of Ebstein's on the plain film because of the dilatation of the right atrium. So tricuspid atresia with a large ASD, you don't get right atrial dilatation. Tricuspid atresia with a small ASD, you can get right atrial dilatation. So that will depend on the size of the atrioseptal defect. And then we have this thing, pulmonary atresia with intact ventricular septum. So here, the right to left shunting occurs at the atrial level because of pain foramen ovale or atrioseptal defect. Cyanosis is severe since very little blood reaches the lung. There's pulmonary atresia, so there's no outflow from the right ventricle to the actual lungs. So in this condition, the blood flow to the lungs is dependent on the PDA. When the PDA closes, death might result. And so that's why babies born with this might be given prostaglandins to keep the PDA open until surgery can be performed, because that's what's supplying blood to the pulmonary circulation when you have pulmonary atresia in these cases. The difference between type 1 and type 2 has to do with the tricuspid valve. Type 1 will have a small right ventricle because the tricuspid valve is competent. Type 2 will have an enlarged right ventricle because the tricuspid valve is incompetent. And then this tricuspid regurgitation leads to right heart enlargement. So type 1 radiographically will resemble Tetralogy of Fallot with more normal heart size, and type 2 will have a big heart, especially with dilatation of the right atrium. So with type 1, the heart is more normal in size. With type 2, the heart is larger with a dilated right atrium. Okay, so that's pulmonary atresia with intact ventricular septum. And so in this condition, then the blood from the right ventricle has really no place to go because there's no VSD and there's pulmonary atresia. So if there's regurgitation of the tricuspid valve, it would go back into the right atrium. On the other hand, if the tricuspid valve is competent, in some cases, then what happens is that the blood actually from the right ventricle can get into sinusoids in the wall of the right ventricle, and these sinusoids can communicate into drain retrograde actually into the coronary arteries, because that might be the only outflow for the right ventricle. And then that results in desaturated blood getting to the coronary arteries and can be a cause of sudden death. So that can be a complication of this form of pulmonary atresia with intact ventricular septum. All right, so let's move on to our next case. Okay, and so here, right atrium, left atrium. Here's the right ventricle, and then here's the left ventricle. Okay, so here, when we look at the valves, we have the mitral valve here on the left side, and then we have the tricuspid valve there on the right side. So who can tell me what do they notice about the tricuspid valve in this case? A little bit, yeah, but what else about the whoops, well, that kind of gave it away, but what else about the tricuspid valve? Yeah, it's displaced apically, and that condition, of course, is called Ebstein's, right? So Ebstein's gives you dilatation of the right atrium and the right ventricle. So the right side of the heart, the chambers here on the right side are dilated. Right? So with Ebstein's anomaly, there's this malformation of the tricuspid valve where it's displaced towards the apex of the ventricle, and so the leaflets are attached almost to the right ventricular wall. So there might be incompetence of the tricuspid valve, and this causes atrialization. This portion of the ventricle is atrialized because functionally it becomes a portion of the right atrium instead of part of the right ventricle. So there's a functional obstruction of blood flow through the right heart that can result in right to left shunting across an atrial septal defect or pain foramen ovale, and that's why these patients can have cyanosis with decreased pulmonary blood flow. And the obstruction of flow through the right heart results in dilatation of the right heart. There's a broad spectrum of severity with larger atrialized right ventricle. There's more physiological derangements, and this may improve with decreasing pulmonary vascular resistance after birth, or worsen if there's spontaneous closure of the PDA. But with mild disease, it can be asymptomatic until adulthood, and this is the most common cyanotic congenital heart disease that might present in the adult is a mild form of Ebstein's anomaly. Another abnormality that can be associated with this is arrhythmias. So arrhythmias can also be associated with Ebstein's anomaly. Now, the classic radiographic manifestation of Ebstein's, what do we have? Well, before we get there, we talk about the pulmonary blood flow, right? So pulmonary blood flow is decreased, right? And then the heart is enlarged because of usually right atrial enlargement. So it's called box-shaped heart, or wall-to-wall heart is another descriptive term that's been used for this, right? So the marked enlargement of the right atrium. So that enlargement of the right atrium then results in that box-shaped or what's called the wall-to-wall heart with Ebstein's anomaly. So big right atrium in patients with decreased pulmonary blood flow. Okay, so tricuspid valve displaced towards the right ventricle, especially the septal leaflet. You want to look for that. The septal leaflet should be close to the septal leaflet of the mitral valve here, but it's displaced towards the apex. You'll have atrialized portion of the right ventricle, and so that results in functional obstruction of blood flow through the right heart, dilatation of the right-sided chambers, especially the right atrium, and there might be an atrial septal defect or pain foramen ovale that causes right to left shunting in these cases. Now, a few other miscellaneous abnormalities to talk about. Critical pulmonic stenosis. If there is severe pulmonary valvular stenosis with an ASD or pain foramen ovale, that can also result in right to left shunting through the atrial septum. That might also result in right ventricular hypertrophy and cyanosis in an infant. And the treatment for that is they balloon the pulmonary valve to open up the pulmonary valve. So with pulmonary valvular stenosis, they can do valvuloplasty to open up the pulmonary valve with infants born with severe pulmonary valvular stenosis. So in critical pulmonic stenosis, that might also result in decreased pulmonary blood flow with cyanosis if there's a shunting through the atrial septum. And these patients might also have some enlargement of the right atrium because of that. And this is called Trilogy of Fallot, because there's pulmonic stenosis, right ventricular hypertrophy, there's a right to left atrial shunt, but there is no ventricular septal defect. So there is no shunting at the level of the ventricles. And so these patients might also have an enlarged right atrium, and then you can see here post-op, after the pulmonic stenosis is relieved, the right atrium there goes back to normal in size. Okay? There's also transient tricuspid regurgitation of the newborn, and what happens here is, because the pulmonary vascular resistance at birth can be very high, that increased pulmonary vascular resistance causes obstruction of blood flow to the pulmonary circulation. And these patients, if they have a pain foramen ovale, can get right to left shunting across a pain foramen ovale. This is self-limiting, so as the pulmonary vascular resistance drops, that the tricuspid regurgitation decreases and the cardiomegaly resolves. So that's called transient tricuspid regurgitation of the newborn. So they might also have an enlarged right atrium with decreased pulmonary blood flow at birth, and then over time, as the pulmonary vascular resistance drops, the right atrium goes back to normal in size. So this is a rare disease I'm illustrating to you here, thin-walled, poorly functioning right ventricle. So this is a congenital cardiomyopathy that affects the right ventricle, or the right side of the heart, mostly the right ventricle. So these patients will also have dilated right atrium and right ventricle. Okay. So what is this rare disease? What is this called? This is Ewell's disease, right? So Ewell's, yeah. So muscular dystrophy is acquired, right? So those patients have disease of the skeletal muscles, that over time those patients develop atrophy of the skeletal muscles. And then what happens is they can develop a cardiomyopathy associated with that. So they develop a dilated cardiomyopathy. And so that can look like all other cases of dilated cardiomyopathy. This is a congenital cardiomyopathy that specifically involves the right-sided chambers. So the left-sided chambers are not involved here. This involves the right ventricle mostly and gives you a thin-walled, poorly functioning right ventricle. Okay? Is that clear? Okay. So Ewell's disease, severe form of congenital right ventricular dysplasia, marked thinning of the free wall of the right ventricle, also called parchment right ventricle, taper-thin right ventricle. So it's a congenital cardiomyopathy that affects the right ventricle. So that is Ewell's disease. Okay? So this is what a more normal-looking right ventricle should look like. With Ewell's anomaly, very dilated, poorly functioning right ventricle. All right? Now, this is a patient looking at a short-axis view of the coronary sinus right here. Normal patient. Here's the abnormal patient. What's wrong with the coronary sinus? Unroofed, right. So this portion of the coronary sinus is missing. So the unroofed coronary sinus is also associated with what here? That's not what I'm pointing to, though. What am I pointing to? It's the left atrium, here's the right atrium. What's missing? What does this patient have here? Well, what does this patient have here? There's an atrial septal defect, right? So unroofed coronary sinus can also be associated with an atrial septal defect like you see here. And if these patients sometimes can have persistent left SVC, which then drains to the coronary sinus and then winds up draining into the left atrium. So this is a very rare form of an atrial septal defect here. This portion of the atrial septum can be deficient in patients with unroofed coronary sinus. And if they happen to have a persistent left SVC, then the left SVC can actually wind up draining into consists of left SVC winds up, because of the unroofed coronary sinus, draining into the left atrium. Okay, so that is unroofed coronary sinus. All right, so let's move on to the quiz.